As Dr. Yance mentioned, I'm the director of the Department of Health Services for Los Angeles County. The cases are measured in a variety of different ways, and I know you all know well, and I won't even try to educate you all about it, is the one that matters for school reopening is the adjusted case rate per 100,000. And last week that was at 39. This morning, the state reported Los Angeles County, again, declining rapidly down to 31.7, and Department of Public Health, Dr. Ferrer mentioned this morning to the Board of Supervisors for Los Angeles County that she anticipates that that rate will decline below the threshold of 25 needed to open up the lower grades by next week. The CDC finally came out with a position about 2 weeks ago in an article in JAMA, which is one of the two preeminent medical journals out there, offering their thoughts finally after a number of studies had been published about the safety and the viability of school reopening. And I pulled a couple of quotes from the JAMA article here. The citation is below. It's worth a quick read. It's a very short article. And I'll talk through just a couple of studies that they found were the most important for lending and determining their position. So first, they mentioned that there's little evidence that schools have contributed meaningfully to increased community transmission, that in-school attendance during the 14 days prior to diagnosis is not associated with COVID infection, and that the preponderance of available evidence, and it is the preponderance, we'll talk in a little bit, you can always find a study that supports whatever point it is someone wants to put forward, but the preponderance of available evidence from the fall school semesters in other jurisdictions which weren't as conservative as California was in reopening schools has been very reassuring in that you don't see the type of spread coming from schools that you saw in other types of congregate living settings or other types of work locations. When there are school outbreaks, the CDC calls on a number of different factors, and specifically they highlight 4, because again, you can always design a situation that's not safe, and the important factor is how do we move together in a way that is safe? And they commented on 4 main things that were behind the school outbreaks that they did see, and again, the number of outbreaks was very small in the United States. When it happened, it was because of crowded classrooms where they didn't have sufficient physical distancing. They didn't follow some of those 4 feet, 6 feet rules. They did not have, most importantly, they did not have strict controls on face masks. And in certain school districts, they didn't even require the use of face masks by children. And that was always associated with outbreaks. Some locations, particularly in some of the warmer locations, they used a continuous air conditioning that would recycle rooms rather than relying on either a ventilation system or just as good open doors and windows. And then sometimes, very often, and this is what we've also seen in California and some of the outbreaks, particularly in Los Angeles and the schools that did open, was that school sporting events, the teams chose to travel out of county and out of state, and those opportunities of travel, while great for the kids in terms of sports, not great for transmission. And we saw that very often it did result in increased community spread as stemmed from that school sporting event. The next slide, please. I'll walk through just very briefly the 2 main papers and then touch briefly on the third that the CDC cited as support of what they were looking at. And again, the citations are all below, and I would highly encourage anyone who's interested to take a look at the paper. This first one was a study that was done in North Carolina schools during their fall semester. The large study population, more than 90,000 staff and students, they looked across grades. This was elementary through secondary school. The CDC's recommendation of note does not just apply to earlier grades, K through 6. It applies across the breadth of K through 12. It was in the setting of widespread community transmission in some of these locations. And what they found was that there were some infections in the school, 773 to be specific, but that only 32 additional, and those were community-acquired infections. So they did robust contact tracing of the individuals that had an infection, and those people had acquired the infection from outside of the school setting. When you looked at whether or not this is really what you want the studies to look at, isn't so much, did people get COVID in the community? If COVID's in the community, people are going to get COVID in the community. That's the definition of what's happening out there. What you want to know is, did people spread it at school? So you want to know, did people look at secondary transmission versus what you would call primary transmission in the community? And in this study, there were only 32 cases of secondary transmission or spread at school. And critically, I think it's important to note that there were absolutely zero incidences of child to adult transmission. All of the transmission was child to child. And again, I commented before on some of the specific situations in which they found led to some of that child to child transmission. You go to the next slide, please. Very similar study that also looked importantly at secondary transmission. This was a study in Wisconsin during the fall semester. Again, they looked at K through 12. They did not just focus on primary education. Almost 5,000 students, about 650 staff. Again, widespread community transmission and very high test positivity rate in some of these locations, up to 40%. Los Angeles County has never been at 40% except for very early in the pandemic when there was virtually no testing. Since then, even in the height of the surge, it maxed out at about 21% positivity. So this is double the percent positivity at this site in Wisconsin. And they did importantly have really high compliance with mask wearing, and the article emphasizes how critical that is for helping to maintain safety in the school. They also looked at primary transmission of how many cases were acquired through the community. It was 191, mostly students, a few staff. You know, people, if you're going to go out in public, people are going to get exposed to COVID. Only 7 cases in this case were then secondary transmission. And again, all 7 of those were from students, to students. No cases of adult transmission, no cases of child to adult staff, teacher transmission that was found in this case. And they have a nice graph showing in the top line the overall transmission within the community, and then the small dotted lines at the bottom, one of which is barely visible, is the cases and the rate of transmission within the schools, and then the dotted line that really mirrors the zero baseline is the secondary acquisition of cases within the schools themselves. Next slide, please. This one didn't look at secondary transmission, but the CDC cites this study in several of their pieces of work. And it's an interesting study that was done by the University of Mississippi, where they looked at a much smaller sample size. They were looking at about 400 kids, all children aged 2 to 18. They were coming in to an outpatient clinic or an emergency department for a test, for COVID tests. And they did cases, these 400 cases, and then they did controls, case control study. And they found, CDC put out a nice little graphic, that the cases were clearly linked to outside of school gatherings, that the people who ended up getting COVID, they'd gone to weddings, parties, play dates, they had been involved in some sort of a community activity. And the thing that after robust statistical analysis was not associated with the cases among the children was it wasn't related to attendance at either childcare or in-person school. Next slide, please. As I mentioned, there's a lot of studies out there. And I think it's important, just as important to look at good studies, it's to understand the other studies out there and how they should be interpreted. Because as we all know, you can find whatever you want in the literature or in the data. You can use it in a way that supports your opinion. And it's helpful to try to look out for some of the common pitfalls so we don't fall into some of those traps about some of the ways in which studies weren't intended to be used. And I categorize these among 4, and then I'll highlight a few studies that I think are commonly looked to and why it's not advantageous to interpret the data in the way that some people want to. First, always good to look at peer-reviewed studies. Just peer-reviewed studies are better as someone's looked at their data, someone's looked at their methodology and approach, and it's a more robust analysis. Second is really to look at the context of the findings. A good example of this is the Tulane put out a very good study. It's an excellent study. It's the first citation here, where they looked at the impact of COVID on hospitalizations. So it wasn't looking at overall case rate, it was looking at hospitalizations. And I think that's an important indicator because in the end, you know, that's what you care about is how sick someone got. If all someone did was get an infection, but it's a minor cold, it doesn't really matter. What you care about is whether or not that infection led to hospitalization or led to a serious outcome. And the study tried to look at that. What they were able to find was that in the absence of in the lower transmission, so in the 0 to 75% of the districts where they were, or counties, divided by counties, where there was lower transmission, it was very clear that there was no impact of the school opening on COVID-19 hospitalization rates. The study, however, could not make a determination in the 75th to 100th percentile schools for whether or not there was an impact on hospitalizations. And I've seen this study be taken out of context numerous times by the mainstream media because they've used the study to say that school is safe when it's not a lot of transmission in the community. But when it's higher transmission within the community, school is not safe. And that's just not what the study says. The study says that it is safe when it's lower rates of community transmission at the 0, so 75% of all the schools, it's safe. And then the study just couldn't determine. Some ways they looked at the data, they thought that it did lead to increased hospitalizations, and in some counties it was clear that it didn't. So the study itself, I pulled the quote directly from the article, the estimates are inconsistent across methods and are therefore inconclusive. And I think it's really important to not make an article say something that it's not trying to say. So they themselves, the authors, never intended for this study to be used as making a statement about whether or not schools, when they're having widespread transmission, whether it was safe or unsafe. And the first two studies that I presented a minute ago were done with widespread transmission, and they were able to determine that it is possible to do risk mitigation in a way that can make schools safe. The third thing here to watch out for is just what I just mentioned, is those mitigating safety measures. Israel is the classic example here. There's several studies about what happened when Israel tried to reopen schools. They had a number of outbreaks, and they had a number of outbreaks that had poor consequences. And there were real clear reasons why they had outbreaks. There wasn't consistent use of masking. There wasn't good ventilation. They closed the doors and the windows when it got hot rather than having that open air circulation. And there were obvious reasons why the transmission within the schools, when they had the couple of outbreaks over the few days that they did in the Israeli school system, why they had the results that they did. And so I think it's also important to really look at what the schools did to be safe, because that's in the end what is important to replicate. And then the fourth category here is really on study methodology. It gets in depth into epidemiology, and really these studies should be interpreted by experts in epidemiology, but I'll point out a couple of things. One, which I already mentioned, is that it's better to look at secondary spread rather than community case rates. Otherwise, all you're doing is telling the obvious, is that if you have high rates in the community, you have a lot of people infected. What you want to know is, did the school setting itself provide a location for that infection? And that's what the first two studies showed largely did not happen, or happened at very low rates and could be significantly mitigated. And then the second thing here is that oftentimes many studies, and I cited two of them here, two commonly cited studies. One is a study in Washington State and Michigan schools, and another is a study in, I think it's Florida schools, where they just didn't control for the confounders. You would have huge differences between the different study populations, and then they would attribute the difference to school opening rather than to some of the other things that were going on. So the two areas would be massively different in terms of people's acceptance of mask wearing, but then they would blame the school reopening on the different case rates rather than blaming the different case rates on mask wearing. Different socioeconomic differences, different political affiliation, and we all know that that has implications for a number of things, including mask wearing. The risk mitigation efforts within the schools themselves, sometimes those weren't taken into account in the studies, as well as the community's overall willingness to really take on viral suppression efforts. So I just want to caution people, when you're reading the literature or listening to people speak about the literature, especially the mainstream media, that these studies all need to be looked at carefully and try to understand what they were looking at, and importantly also what they didn't look at. Can you go to the next slide, please? So what does the CDC say is important? It's really 5 things. So number 1, consistent and correct use of masks. Consistent and correct. Has to cover the nose, has to cover the chin, can't have lots of loose gaps, can't have holes in it. It has to fit well, and it obviously has to be worn. If someone's not wearing their mask, it doesn't work. Can't tell you the number of times I see people wear their mask around their wrist, wear their mask around their chin, and they say they're wearing a mask. They're not wearing a mask. Second is social distancing, physical distancing as much as possible, hand hygiene, cleaning and disinfection practices, and then contact tracing. And then I listed the variety of other secondary strategies that the CDC states are important to help make schools safe for everybody. Next slide, please. What's notably not on that list are three things, and I'll talk just a little bit about them. Vaccinations are not on the list, untargeted testing, and symptom screens. On the last one, symptom screens, and I won't touch on it more, the CDC does not recommend a screening procedure, for example, where you take temperatures at the door every day. They do strongly recommend that parents need to screen their children and staff need to screen themselves for symptoms, and people need to be expected and held accountable for not going to school sick. But the screen itself of taking a temperature just is not effective. And it's not effective because of a large number of people that don't have symptoms. Not effective because you can easily mask a symptom if you really wanted to with Tylenol or ibuprofen, as everyone knows. Kids tend to present differently than adults, and they present with fever much less frequently. And so, it also can exclude other people from school if they have other conditions or disorders, and unnecessarily exclude people from school. So for all of those reasons, the CDC does not recommend symptom screen by the district itself. And then I'll talk a little bit more about the next two. Can you go to the next slide, please? So the role of testing. I've learned more about testing than I've ever wanted to know. Among our roles within the Department of Health Services has been to lead the community testing rollout for Los Angeles County. So we've been responsible for leading access to testing for all 10 million LA County residents. And I've learned a great deal about testing. It's come a long way, I will tell you. There's four main roles of testing: diagnosis, screening, surveillance, and outbreak response. And the priorities within populations for testing are really three main things. It's diagnosis. So if someone has symptoms or signs of COVID, it's important to get tested. Second, contact tracing. If you had a contact with someone who had COVID or a suspected contact with someone with COVID, and this is similar to an outbreak setting, then it's important for contact tracing purposes to have testing done. The area where it's deemed optional is then also if public health officials decide they want to do some sort of a random sampling, and that's for surveillance. What's not recommended by the CDC is routine screening testing. And I'll walk through why the CDC does not recommend routine screening, and also why the vast majority of public health bodies also do not recommend routine screening. And there's just a quote down there from the CDC about their position on testing within schools. Next slide, please. So we'll talk more about this, but it's really three main things. In an untargeted population, there's a very low probability of disease. COVID actually has a very short period where you're able to transmit the virus and where you're infectious. And then the test characteristics are very far from perfect. So next slide, please. There's two main types of tests at this point, and it's evolving all the time, so we'll have to see where things go. There's the PCR test, which is the gold standard test. That's the one that's typically done in your nose, back of your nose, front of your nose, sometimes on the oral saliva. All of those different routes have different sensitivities and specificities. And then there's antigen testing. That's the rapid test. This is the one that people like because it's quick. PCR test takes a little bit longer to turn around. It typically takes 24 to 48 hours because it has to get sent off to a lab, where antigen test can be a rapid test that's done often within 15 minutes or 30 minutes. However, the test characteristics aren't great for antigen testing among routine screening. And the sensitivity or the likelihood of picking up a positive case is pretty good. Okay, I would say in a symptomatic population, 64 to 80%, though in PCR, it's above 95%. But when you get to an asymptomatic population without an exposure, so this is your screening population, they don't have symptoms, they didn't have a contact with COVID, you're just testing them just to test them. The test characteristics are terrible for sensitivity. It's, you might as well not even do it. And for that reason, the Los Angeles County Department of Public Health just finally put out a health advisory. Many other public health institutions have as well, advising about how poor this test performs in asymptomatic populations. So they do not recommend any further the use of antigen testing among the general population. And then the only use of asymptomatic testing would be PCR test, which has a longer turnaround. Next slide, please. So there's a fun calculator, if anyone wants to look at it, put out by the British Medical Journal, BMJ, and you can just Google BMJ COVID test calculator. But it'll let you plug in a variety of test characteristics and see what that means for your population. So if you decide that your population is 20% likely to be positive, and that was, a couple weeks ago during the surge, the test positivity rate was running at 20%. Now, those are the people that decided to go get a test. So already you're selecting for people that think they're infected. But if you set that test threshold, what we call the pre-test probability at 20%, you end up getting mostly true positives. You'll get a few false positives, 3 out of every 100, 19 though true positives. So that's pretty good. However, if you go to the next slide, the portion of the population that is actually positive with COVID right now and walking around is nowhere near 20%. So we model this data weekly. The most recent data is at 0.28%. It peaked in the surge at about 1.25% of the population in Los Angeles County was infected with COVID and actively infecting others. And it's important to remember that number is much different, again, than the test positivity rate, because this is the general population where test positivity rate is selecting for people that think they had a contact, think they had symptoms, think they have some reason to have a positive test. So the real pre-test probability among a asymptomatic population is right now at less than 0.5%. So if you go to the next slide, and I do love the BMJ calculator, but it doesn't let you plug in fractions. So you have to plug in a pre-test probability of 1%. And if you go with that 1%, you see why this becomes so problematic in an asymptomatic screen population. So for every 5 positive tests, 4 of them are false, 4 of them are wrong. And so now your probability of having COVID with a positive test is only 20%. And because I plugged in here 1%, it's actually much worse than that, because the number is almost practically 0. This grows to the point where even, out of every 20 tests, out of every 15 tests, only positive tests, only 1 of those is a true positive. So if you do these asymptomatic screening, you end up with a lot of people who get given a positive test, but they're not positive. And then they get excluded from school, they're worried, they have to quarantine, which has implications for them and their family, and it's an unnecessary test to do. Next slide. The other problem with testing on the weekly thresholds, which is what I've seen a lot of school districts look at and try to do, is just the window of positivity for COVID is actually quite narrow. So when your test turns positive, it turns positive at virtually the same minute or hour that you're infectious. So that's good, at least those 2 overlap. And then you're positive and able to transmit the virus for a period they believe of about 9 days. And that's the red and the yellow, but really it's the first 4 to 5 days. So that's at the very top, those first 5 blocks. Once you're positive, you're really able to transmit that virus to other people for 5 days, maybe another 4 after that. And I won't walk through this in detail, but you can see how then it really matters when you get your test. So for example, if you get your test the day before your test turns positive, you miss virtually the entire window and you're out there infecting other people and other individuals, despite the fact that there's a lot of false security that you've gotten from your negative test because you're only testing weekly. And so in the absence of a test out there that's on the market that has rapid turnaround, that's able to be done daily, routine asymptomatic testing doesn't work. And I calculated the math here, but you're only reducing the exposure during that highest risk period of transmission by 17 to 29%. So 71 to 83% of all of the days of your transmission are still out there and you're actively infecting others. Next slide. So this is another study that was done in San Francisco on a number of schools that had opened up, and it shows this same point. And they studied it It's a little bit small and sorry, a little hard to read, but they showed that both monthly testing and weekly testing did not result in reduced transmission in schools. And what was successful at reducing transmission in schools was in all grades was masking, stable cohorts, 2-day staggered grades, and 2-day half-class shifts. So again, it's those core principles of masking, physical distancing, cohorting, and the same things that the CDC mentioned have the most impact. Next slide, please. I'll touch briefly on vaccinations and variants, and then I'll finish up. Everyone knows there's 2 vaccines out there, Pfizer and Moderna, both passed in December. There's a third one that submitted their EUA on the 4th, and it will be pending. They have a likely FDA will most likely grant an EUA on that towards the end of February. There are different types of vaccines, very large studies. These were very large studies that were done with a large number of study participants. And because of that, they were able to determine both efficacy or the effectiveness of the vaccine, as well as the safety. In all of the vaccines, there's been no serious outcomes from any of the vaccines, and they're all effective. The Pfizer and Moderna vaccine are both about 94, 95% effective at preventing symptomatic infection after 2 doses. The Johnson & Johnson vaccine is a 1-dose vaccine, and it's somewhat less effective, but I would argue still a better vaccine because it's only 1 dose. And it's more effective after 1 shot than either the Moderna or the Pfizer vaccine is after 1 shot. And it's 85% effective at controlling what it is you want to control, which is the severe disease and the hospitalizations. Unfortunately, none of them can be used in kids. They weren't studied in kids. Pfizer, they looked at kids 16 and over. The other 2 vaccines only studied in 18 and over. There are some studies that are going on within teens, but none of them have been studied. There's no data yet to date, and none of them have been studied in younger populations. And then everyone knows there's the cold skin issues, especially with the Pfizer vaccine. Next slide, please. This is the Department of Public Health chart on who they're actively vaccinating. They're still in phase 1A, which is the healthcare workers and skilled nursing facilities and long-term care facilities, and what they call tier 1, phase 1B. Which is the residents 65 and older. And then they announced again this morning that they intend to start the rest of tier 1, which is education and childcare workers, importantly, as well as some other sectors, and then tier 2 later in February. And the vaccine is important, but as should be obvious, those studies that were done that I shared a little bit ago from the CDC that showed about safe school reopening and effective mitigation of risk, none of them had a vaccine prevalent available at the time. And so this led the new Biden-appointed director of the CDC, Rochelle Walensky, to comment the other day that the vaccination of teachers is not a prerequisite for the safe reopening of schools. That's not to say at all that we don't want teachers to be vaccinated. We want everyone to be vaccinated. But thankfully, and this is just good news, thankfully, it's not a prerequisite. And there's other measures that are possible to make school reopening safe. Next slide, please. Even if, apart from the supply chain problems on the vaccine, there's 3 issues with really relying too much on vaccines. 1, nothing's 100% effective, nothing. Second, the vaccine trials only studied whether or not someone got sick from COVID. They didn't study whether or not it prevented transmission of COVID to others. So that question is still out there and is unknown. And then there's the role of variants, which we'll talk about next. Next slide, please. Viruses mutate. That is what they do. That's why we have an annual flu shot. That's why you see just viruses change over time. And that's why oftentimes they're very difficult to develop effective vaccines for. There are lots and lots of variants of COVID. The 4 that I'll comment on here, I'll comment on only because they're notable for certain strain characteristics. The California variant, Cal 20C, was just identified about a week or 2 ago, finally sequenced through CEDARS and a number of other labs. And it's probably the predominant strain in Los Angeles County. At least half of the infections are thought to be this variant. And many people think maybe it's why the surge was so serious in the winter. It's probably more infectious than some of the other strains. The other ones you'll hear about the most are the B117, the UK variant, It emerged in September, came in the US in December. It's in Los Angeles County. There's been at least 5 documented cases. It's really important to note that there's very little sequencing that happens still in Los Angeles County. The vast majority of viruses and positive tests are not sequenced. So it should be assumed that it's pretty widespread and will only get to be more widespread. And it's at least 50% more transmissible than some of the other viruses. Jury's still out on whether or not it's more lethal. There's the South African variant, B.1.351. It emerged just slightly later than the UK variant. This is the one that's really been most notable because it's unclear that the vaccines work as well against the South African variant. It was identified in the United States in January. It's in at least 2 or 3 states. It's only a matter of days, I believe, before it's going to be sequenced in California. Just given how global of a world and a nation we are, these viruses spread. And just because it hasn't been specifically identified doesn't mean it's not there. And then there's the Brazil variant. People are still learning a lot about this variant as they are with all of them. It also came into the US in January, emerged from Brazil. There's some cases in Japan. And people think that it's quite similar to the South African variant. Probably some increased transmissibility, probably a greater risk of reinfection. So maybe you're not immune. Once you get this variant, you can get COVID again. And again, maybe not as efficacious against the vaccine. And so very likely, we're going to end up in a situation where COVID is just part of our lives. COVID is with us. It's not going away. It's going to continue to evolve and to mutate and to change over time. And the goal can't be getting rid of COVID, because I don't think that's a realistic goal. The goal is about learning to adapt and live with COVID and have vaccines that are established and widely available over time that themselves need to continually evolve. And it's really about putting in place the practices that can keep people safe while COVID is circulating within the community. Next slide, please. And you'll see just here, this is from the UK. It's not California data. I couldn't find a nice pretty chart like the one they made for the UK. But this is just classic of how viruses change over time. This is from all of last year and the strains that were dominant in the United Kingdom over the course of the year. So when you hear about variants or the UK variant or the South Africa one or the Brazilian one, it's not that this is something new or different. This happens all the time, every day, every week. These viruses are changing, and we shouldn't expect that it's going to be any different in California. Next slide, please. So I'll wrap up there. I would just say that, I think the core focus needs to be on safety and on risk mitigation and on how do we use what we've learned throughout the pandemic, what we've seen happen in other jurisdictions, in other counties, other states, other nations, and how do we learn from that, look critically at the data, look at what works and what doesn't work, to put in place effective steps for building confidence among parents, among teachers, among administrators, among the community for what can be done to keep people safe. And in turn, then helping to make sure that the community is thriving, the students are thriving, and everyone can work towards safety for everyone and overall well-being of our entire student and workforce. And with that, I'll close, but I'm happy to take any questions if there are any.